Good afternoon, everyone. I'm not sure if I'm in a friendly audience here or an unfriendly audience, so I would like to have my first disclosure, and that is that I do both on and off pump surgery. I think as a surgeon, we all have lots of tools, and what makes a good surgeon from a bad surgeon is a good surgeon knows when to use the right tools. And on and off pump surgery are really just tools that we have to make our outcomes best for our patients. So I think we all should do both. The question is what really should be our predominant strategy for surgical revascularization? So I've taken the liberty of changing the title of my talk a little bit, and I'd like to change it to off-pump CABG should be abandoned as our default procedure, and that on-pump surgery really should be what we mostly do, but we have off-pump in our armamentarium of tools to use when we need them. Now, to convince you of this, I would like to talk about three things that we know about the differences between on and off pump surgery in terms of procedural outcomes, the quality of the revascularization that can be done, as well as the long-term effectiveness of each procedure. Now let's start with procedural outcomes. Very soon you're going to see a large meta-analysis of over 100 trials that's being put together by ISMICS, but this is a earlier meta-analysis of 37 randomized trials, and I think the interesting thing is, and I had the opportunity to sit on the ISMICS panel, is that the differences are going to be really no different than what we learned at 37. We've just subjected a lot more patients to trials. But what we found, and what has been found, is that if you look at really what we might consider to be the very important hard endpoints, maybe some of the irreversible things or complications that we do, such as mortality, myocardial infarction, stroke, and renal failure requiring dialysis, is really no different in on and off pump patients. There have also been three very large randomized trials that I would like to talk about. There's the Roby trial, coronary, and the CABG. Now, many of you are familiar with these, but just to remind you, the Roby trial, which I'll talk about first, was a randomized trial that was done in the United States at, I believe, 18 different Veterans Administration hospitals. Now, this trial has been maligned by surgeons who do off-pump surgery, and what I would say it's been unfairly maligned. And the reason it's been maligned is that they say that the surgeons who did the off-pump operations were not experienced enough, and that many of these operations were done by residents. And secondly, that this study included patients that were too low risk. And these kind of statements is what led to coronary and CABG. So I want to present all three of these at the same time, and I want you to see that the outcomes between the three studies are no different. Roby saw and demonstrated what was seen in the previous meta-analysis. Again, similar mortality, similar stroke, and similar acute renal failure. Coronary included almost 5,000 patients, and again, similar outcomes, no difference in mortality, MI, stroke, and acute renal failure. Now, what they did in coronary and CABG were two things that were very different than what was done in the Roby study. First of all, they included more high-risk patients, and this was defined by maybe elderly patients, I believe that was in CABG, and in coronary, patients with significant comorbidities, diabetes, vascular disease, carotid artery stenosis. So put those patients in a higher risk. And they also did something what's called an expert-based randomized study. In Roby, the patients were just randomized either on or off pump, and it was done by the same surgeon, did both on and off pump. In an expert-based study, an institution would randomize the patient, but at an institution, they would have experts in on pump and experts in off pump. And if the patient was randomized to off pump, they went to an off pump surgeon. And so this is how you could ensure that you only had surgeons who were experienced with that technique doing the studies. Again, however, despite those two differences, you'll see similar procedural outcomes in coronary as well as in CABG. And CABG, I think, enrolled about 2,500 patients. So in these latest studies, we've had over 10,000 patients really not showing any difference in those important hard endpoints that we see in hospital. Now, one of the things that I think is true about off-pump surgery is that probably some of those reversible complications, atrial fibrillation, maybe they spend more time on the ventilator, is reduced with off-pump surgery, and that's been shown in the meta-analysis, and I think you will soon see in the ISMIC meta-analysis as well. One of the disappointments, I think, of off-pump, and those of us who were very excited about it in the late 90s, was the ability to reduce the neurocognitive changes. We've obviously found out over the last 2 decades that a lot of those things that people said about the effects of bypass surgery and neurocognitive dysfunction are just not true. And when you look at on and off-pump surgery, in the long run, there's really no differences in neurocognitive changes between the two procedures. One of the things that we don't like to talk too much about is the risk associated with conversion. We know that when we convert a patient from off-pump to on-pump, that is associated with risk and risk for the patient. And a lot more than we would like to say. We see that there's higher mortality, higher bleeding, higher renal failure, higher risk of stroke, respiratory failure, and GI complications. And that's probably due to often, at least early on, a lot of these conversions were done in kind of an emergent or semi-emergent situation. Now, surgeons today will tell you conversion is no longer a problem. I know when I can do something on pump and off pump. However, if you look at coronary, CABG, and RABI, we see about a 10% conversion rate, a 1 in 10 conversion rate from off pump to on pump. And again, in coronary and CABG, these are experienced surgeons, surgeons who have done several hundred off-pump procedures, again with a very high conversion rate. When we convert a patient from on-pump to off-pump, that conversion is done before the patient is cannulated. So it's not done in an emergent situation and is therefore not associated with the complications of converting an off-pump to an on-pump. Okay, how about the quality of revascularization? I think we were some of the first people to show in a study that we performed and presented at the ATS that the quality of revascularization was not the same, and that there was more incomplete revascularization in patients undergoing off-pump surgery. In other words, there were fewer grafts. If you take a look at some randomized studies that actually looked at completeness of revascularization or numbers of grafts, in the randomized studies show fewer grafts. And again, we have to remember that when someone is entered into a randomized study, there is felt to be equipoise that you can do the same operation on or off pump with equal effectiveness. And what we see that even in the randomized studies, they are not being performed equally effectively with fewer grafts and more incomplete revascularization. What do we see in the latest studies? Again, in these 10,000 studies of coronary, CABG, and RABI, we see the same thing. We see fewer bypass grafts. So although it's been almost 2 decades, we are still having the same problems with the effectiveness or our ability to do the same quality revascularization. This is a Cochrane meta-analysis looking at 57 studies, which once again shows the same thing. Fewer bypass grafts are being performed in the randomized studies in off-pump patients. Again, more incomplete revascularization. And those of you who were with us this morning, we talked a little bit about residual ischemia and how that was bad for outcomes. And again, that's what we would expect. And as we all know from many studies, that incomplete revascularization is not the best thing for our patients over the long run. How about graft patency? If we're going to talk about effectiveness, we know we have fewer grafts, but do those grafts stay open as long? Some randomized studies that have shown graft patency have shown that it's decreased in off-pump patients. So we have fewer grafts, and they are less likely to stay open. If we look at the results from the ROBI trial, what we see that overall we have lower graft patency in both arterial grafts, the IMA grafts, as well as in saphenous vein grafts. And an important thing, just like incomplete revascularization, if we have residual ischemia, the expectation is that the patients will do worse. Here's a study out of New York that looked at if you had 3-vessel disease, the number of grafts that stayed open was directly correlated with how well you did over the long run. So if we have fewer grafts and our grafts are less likely to stay open, we're obviously going to affect the long-term outcomes of our operations. And there's even suggestions in these expert-based trials, we already know they have fewer grafts, but also that the quality of revascularization isn't the same because there are a higher 30-day need for intervention in these studies in the off-pump patients. Again, fewer grafts aren't staying open as long, requiring patients to go back within 30 days to have other procedures done to get rid of their ischemia. Well, obviously those would all suggest worse long-term outcomes, and that's what we see in the Roby trial. We see an increase in cardiac mortality in patients who underwent off-pump surgery. And the Cochrane meta-analysis that I alluded to earlier with 57 studies, again, shows higher mortality in the off-pump patients. And I think what you will all see in the ISMIC's paper when it comes out is that after 1 year, there is higher mortality in patients undergoing off-pump surgery. The Roby trial, again, showed a worse composite as in addition to death. And this is another study out of New York, again, showing worse long-term outcomes in patients undergoing off-pump surgery. So I think, what can we say? Let's summarize about what we've talked about. We can see that the procedural outcomes, we can have similar mortality, myocardial infarction, and stroke. We do, though, however, have lower what I would call reversible complications by doing a procedure off-pump. But we do have a greater risk associated with conversion. The quality of revascularization is just not as good with off-pump surgery. We have fewer grafts, more incomplete revascularization, and greater need for reintervention. And therefore, as we would expect, the long-term effectiveness is not the same. We have higher mortality and the need for more reintervention. So I think we should conclude that although off-pump surgery is a tool that we should use, particularly in our patients maybe high risk of stroke, that it shouldn't be our primary revascularization strategy because we have similar early risk but less effective revascularization that leads to worse long-term outcomes. Thank you very much.